This is the 2 o'clock, now 2:15 session on building an equitable innovation ecosystem with emphasis on what's actionable and drawing upon leaders from various important players in our ecosystem. I'll introduce them in a minute. I just want to say a few words. I think this has been a terrific day's program. It's really the culmination of 4 years of effort around these topics and the creation of CESTI itself and its reports. It was very impressive to me to hear how similar the developments have been in the OECD. Reports track very complementary fashion, and I think their focus on their reports and objectives and actions there, especially international, of course, which could include the United States, are a nice stimulus for carrying forward our own work. It's also a pleasure to note, since I'm an old-timer, that the Belmont principles are still holding, and the CESTI principles of justice, autonomy, fairness, community good, and individual good is built directly on the Belmont principles of justice, autonomy, beneficence, and non-maleficence. And the non-maleficence always requires an explanation, but it's reality that there are negative forces alight in our society and in every society, and we have to be aware of inappropriate or malevolent developments from innovation. Our panel, I can't see everybody's name easily. I think I'll start with Sam here. Sam Gill is the president and CEO of the Doris Duke Foundation, very active in funding translational research. You have the rest of the information in your paperwork. I will be as brief as practical. Dr. Alicio Perez Estabal is director of the National Institute on Minority Health and Health Disparities, a very important component of these centers and institutes at the NIH. I had the pleasure of serving on that advisory council many years ago. Dr. Holly Fernandez Lynch is a lawyer and a bioethicist on the faculties at the University of Pennsylvania. Dr. Erica Kimmerling is Assistant Director for Community-Driven Health at the White House Office for Science and Technology Policy. And finally, on the screen, welcome, is Dr. Susan Monarez, a Deputy Director of the ARPA-H, Advanced Research Projects Agency for Health. So I'd like to ask each of you to say a few words about the role that you and your agency or organization play in these topics, and let's say in the ecosystem of research and innovation, and with emphasis on equity. Maybe give us one tangible action that you have taken or considering taking in your organization that would be a lesson of how we can do things better, much more widely. Sam, do you want to start?
Sure, Gil. Thank you very much for including Doris Duke Foundation in this conversation. I'll sort of begin my remarks by talking a little bit about kind of what I think or my answer to the question, talking a little bit about what I think the role of independent philanthropy is. So Doris Duke is a $2 billion independent foundation. We invest in a range of areas from the performing arts all the way to medical research. We've been a significant independent funder of early career support for physician scientists historically, as well as a research funder in particular around sickle cell disease over the past 10 years, which was an interest of Doris Duke's while she was alive. In my view, independent philanthropy is not operating at scale in almost any issue in which it works, and that's probably nowhere more pronounced than in the science enterprise, particularly in biomedicine. I mean, we're spending 8 figures nominally in an enterprise that's $160 to $200 billion a year. The role, I think, in general of independent capital, of independent philanthropic capital in any issue is to do what operators at scale cannot or will not do today in order to inform and shape what operators at scale do tomorrow. It's to be further out on the risk frontier, whether those risks are political or executional or otherwise. Often, the ultimate source of risk for an operator at scale is knowledge. It's understanding what matters, it's understanding how it matters, it's understanding what to do with it in ways that are responsible. And so, for us, the question of investing in bringing equity to biomedicine, to the practice of biomedicine, to the environments in which biomedicine is practiced, is an effort to sort of answer that question. What are there? Can our capital signal what problems matter? Can our capital enable potentially kind of unpopular, technically speaking, views about the nature of those problems? Or can our capital invest in solutions that are just too risky for operators at scale? One issue that we've been working on, per the question about a tangible example, is that in the last year, we have become a relatively active investor in beginning to analyze and bring more rigor to the use of race as a variable in sort of quotidian clinical algorithms and equations. So, the things that happen in a doctor's office, in assessing kind of basic functioning of organs or other health functions. I'm a non-scientist, by the way, that's going to come through in how I describe these issues. But I have been a patient, so, I've been asked these questions. To me, that's a great example of a role that independent capital can play, because there are a couple things that make addressing this issue really tricky. First, obviously, the question of race just is an extremely socially divisive and incendiary issue. Even among well-intentioned parties who are committed to addressing kind of well-documented examples of racial disparities, it's a hard thing to talk about. And so, philanthropic capital can enable and create safety and legitimacy for some of these conversations, particularly when it comes, we hope that we have some track record and credibility around the practice of biomedicine. The other issue that's tricky is that a lot of questions, it seems to me, around ultimately creating more equitable outcomes of biomedical activity is the uneasy bringing together of sort of conventionally objective questions within science and extremely subjective social questions, and the sense that I get from seeing some of the work that we've invested in is that there are plenty of well-intentioned scientists and plenty of well-intentioned scientific institutions that want to be able to say, look, we're just doing science, and it's just a tool. And if that tool is being, we don't have animus, we're just doing science. And the reality is that that's sort of not good enough when it comes to issues like race and clinical equations, because it is the kind of issue that intrinsically brings together conventionally objective scientific questions and the social construct of race. And there are some people who think race is purely a social construct. There are some people who think that race combines some objectively observable elements with social constructs. There's sort of relatively few people in this issue who thinks that sort of society has nothing to do with race and the way that race is used. So you're just inevitably in a very tricky set of conversations about that bring together normative considerations with scientific ones. And so, our role ultimately, we think, is to make those conversations safe. And we think if we can make those conversations safe among scientists who are operating at the highest levels of their disciplines, as well as people who are operating with the utmost conviction about normative commitments like racial equity, then we're probably going to get to solutions. If the conversation remains unsafe, then we're skeptical, that much will be done about an issue that ultimately does lead to a lot of harm, particularly for people of color in this country.
Very good. Let's turn to Dr. Perez Estaba.
So thank you for having me here as a representative from NIH. So I'm a general internist by background, and I've been at NIH for about 8.5 years. So my clinical discipline, for those of you not familiar, was not one that was technology prone or necessarily focused on new pharmacological drugs before they were really out. At the NIH table, I represent a small institute, a little over 1% of the budget of the agency, where we really focus on minority health and health disparities, but would emphasize that the entire agency has that charge. This is not an NIMHD charge only. It's the same thing as we say that only the Genome Institute does genetics research. That's not true. We do about 15% maybe of the minority health disparities research, like Genome does about 15% of the genetics research at NIH. So just keep that in mind. So one approach that NIH does have is we have a budget, and we can persuade people with funding or building resources. And in this context, I would say we have to do the basic things well. And it starts with a conversation we had a couple weeks ago or last week relating to collecting data in a standardized way so that we can actually put it together and leverage the power and the tools of analytic tools that are available today. And we just aren't doing good enough. Now, with race and ethnicity, it's a moving target. People do ask it different ways. There is a standard. The census has a standardized way. So why don't we, if 300 million Americans can answer that question, why can't we use it in all research that we do? You can always do subcategories. So we build towards that. We try to get our community, our scientific community, to say, these are some common data elements or common metrics that we endorse, that we vet through a scientific process and say that a group of experts say these are good measures to measure a variety of different constructs, and we encourage you to use them. We haven't taken the step of requiring you to use it, but we are moving slightly in that direction slowly. A second thing, and I would add, just as comment, we talk about race and ethnicity, but actually socioeconomic status or social class is disastrous. We don't ask our scientists to report on that in their human subjects reporting. They do report on sex and on foreign-born or U.S.-born, and also race and ethnicity. And there's talk about sexual and gender minority status, adding that to that now. But who knows about socioeconomic status? And it's not that difficult. You ask people about their educational attainment, and you have this powerful predictor of almost any outcome that you are interested in. And yet, how many clinicians know what their patients do? And researchers do it, and if they're population scientists or epidemiologists or behavioral scientists usually. But in the clinical center at NIH, they don't ask. You're a patient there, they never ask you about your socioeconomic status. So keep that in mind. We think those are the two fundamental drivers of inequity in the United States. Your race and ethnicity, as you identify it, brings all this kind of history and lived experience that we don't really understand. A lot of it is racism, discrimination, but not only. And then your social class, which, going back several hundred years, we've known about that it relates to outcomes. And then the second thing that we can do is build infrastructure. And hopefully infrastructure that the community will use. So with the measures, the example we have is something called the Phoenix Toolkit, where we started back in 2019 to build a social determinants of health web page in that resource, where we say, oh, these are the measures we are endorsing. And that, I think, has had an impact. Our scientific community does refer to it. We put the link in every funding announcement. And another resource would be to create then a system for people to deposit data if they're all doing it the same way. So we're kind of inching along in that direction. NIMHD is too small and has really not had a presence in the whole data science, information technology world of NIH. That has improved as our resources there, the National Library, primarily the Center for Information Technology and the Office of Data Science strategies especially, have been supporting us in doing this. So create a way for researchers from HBCUs and less resource institutions to be able to ask dumb questions, because they go to a lecture on data science and they get lost in the first 5 minutes and they tune out. But if we go from A to Z with them, just walk them through it, not me, but people who know what they're talking about, then I think we can make a difference and begin to create that. So we're working on that, something we call SHARE. It will be a cloud-based system where we hope to have tools to analyze as well as data, currently publicly available data. It's still in the building phase, so it's not yet accessible, but we hope to by the end of this calendar year. So I'll pause there. There'll be other examples I can share later.
Hi, everyone. I'm so thrilled to be here and just want to commend all of you who've contributed to a fabulous set of reports and academic papers out of those reports. I find myself once again on a National Academies panel in which one of these is not like the other. I'm a bioethicist and a lawyer by training. I am not a funder. I don't, regulate research. I'm not an inventor of some of these amazing technologies that we've heard about. But I study funders and I study regulators and their role in this ecosystem. And so I can kind of offer a bird's eye view of some of what I see as tangible opportunities to influence equity in this ecosystem. And I can start just by talking about two things that I see as helpful steps in the right direction on the funder and regulator side, and then two things that I think ethicists and universities might be able to do. So, one of the most obvious themes I think that we've been hearing all day is that we have to bake equity in from the very beginning, and it cannot be an afterthought. And so funders and IRBs have a helpful role to play, because they are your kind of do not pass go organizations, right? If you want to have money from the government or from some of these foundations, right, you have to convince them that you have a great idea. And so they can put in their application process, how are you going to address these equity challenges, right? We heard Lori talk about these different futures. Envision kind of what's the best case scenario for your project and how it's going to influence equity, and what are the unintended consequences and how might you think about addressing them, right? And so the helpful factor in including IRBs in all of this is that, I get it. People complain about IRBs. They can over-regulate things. They can really be a pain in the neck sometimes. And there are important gaps for research that doesn't have to go through the IRB, so I don't want to suggest that it's a panacea. But IRBs do have the ability to regulate industry research in many areas, even when it is not publicly funded. So that's something that, if you've just forced folks to think about it at the front end, they can't say at the back end, oh, we have no idea. We didn't even imagine that something like this could happen. So that's kind of step number one. The other that I'm kind of surprised we haven't heard more about today, although Sam, you started to, I think, go in this direction, is thinking about diversity of clinical trial participation, and you also, right, are thinking about this at NIH, and so this is a conversation that I think has become much more prevalent, but NIH was at the forefront. It's been requiring, funding recipients to articulate what their recruitment goals are, what their recruitment plans are to get diverse populations into their studies. More recently, we've been seeing this on the FDA side, where I think starting in 2022, there was guidance that was circulated by FDA encouraging sponsors to develop race and ethnicity diversity plans to enroll representative numbers of participants from underrepresented populations, and really walk through the specific approaches, right? You say, this is your goal. Well, how are you going to recruit and retain these participants? And even more recently, we've seen Congress step in and say, okay, this was FDA guidance, but now it's going to be required by law. law that for pivotal studies supporting FDA-regulated pharmaceutical and biologic products, that companies are going to be expected to produce diversity action plans that include goal enrollments for age, sex, race, and ethnicity. And I think critically important that also include a rationale for those goals and specific plans for meeting them. So I think both of those kind of are steps to incorporate equity from the very beginning. Let me just talk quickly about a couple of things that people like me and my institutions might be able to do. So one thing that academic ethicists can do is support efforts to facilitate equitable innovation and encourage trustworthiness of the R&D system by being willing to engage with, advise, and consult with industry. And that does not make me popular amongst my bioethics colleagues. There's lots of ways to do this. We didn't disclose any conflicts. I don't do any, paid consulting with industry, but I am in conversation, right, when my colleagues are grappling with ethical challenges and are seeking advice. So, we have to be careful about this. We need to avoid ethics washing or kind of equity washing where you consult with ethicists, tout the fact that you've consulted with them, but then don't actually follow their advice, or worse, fire them when they give you advice that you don't want to abide by. And we've seen that sometimes happen. But there are some emerging models for embedding ethicists in innovation projects, or, having kind of ethicists in residence programs, both at foundations and within private industry developing these products. And then the last thing that I'll flag on the university side is thinking about the role that universities play in innovation and the levers that they might be able to pull and push in terms of technology transfer. So one bit of guidance, or kind of the way that technology transfer offices are evaluated in university settings, is how much revenue do you produce? That's absurd, right? These are in nonprofit organizations that are, getting tons of public money. And the rationale is, well, we'll bring in all of this money and then we'll use it to advance the educational mission. And I don't mean to suggest that that's totally disingenuous, right? But there are a lot more direct ways of advancing equity. And so thinking about who universities are licensing with, what the terms of those licensing arrangements are, I think is kind of an untapped area to help promote equity. And I said that would be the last thing, but just something that came up in our AI drug development breakout session that I thought was just critically important as we talk about the role of funders in this space is that you have an obligation to allocate your funding in different ways. Don't allocate it all to shiny new toys, right? It's also important to allocate research funding to address some of these critical structural determinants of health that I recognize were not part of the charge of the committee's work, but we of course can't forget about them. So with that, I'll see.
Hello, everyone. Good afternoon. I am Erica Kimmerling. I am the Assistant Director for Community-Driven Health at the White House Office of Science and Technology Policy, and I will likely call us OSTP moving forward. Apologies in advance for my acronyms. So for those of you who don't know, although we've been previously shouted out earlier in the program, OSTP's mission is to provide advice to the President and other White House leaders on matters related to science and technology. We work to strengthen and advance American science and technology, and with federal departments and agencies and with Congress to create bold visions, unified strategies, clear plans, wise policies, equitable programs, and engage with partners. I've actually been at the White House Office of Science and Technology Policy for 3 years now. I had the privilege of working with Dr. Alondra Nelson. And, early on, from the very beginning, our charge has been guided by a question that in a letter from the President before the start of the administration on how can we guarantee that all Americans, all people in this country can share in the fruits of science and technology. And that's been the through line in our thinking, and actually why originally I was brought on. So my original position was a senior policy advisor for public engagement in science, and my charge was to think about how to use the tools available to us related to public participation, whether or not it's requests for information, listening sessions, challenges to shape and inform high-level priority setting. So one of the things we've heard from the very beginning in this conversation is that you need to involve the public in high-level priority settings in order to advance equity. And this is where OSTP has been working to lead by example for the science and technology ecosystem. And you see it reflected in what Dr. Nelson said related to the AI Bill of Rights. It's reflected in our Cancer Moonshot and work really across all of our programs, the National Nature Assessment. Forgot to mention we use tribal consultations in a lot of our work, which is a different, more formal tool for public engagement. So that's one piece of how we're thinking about this work. The other thing I wanted to bring up is that on day one of the Biden-Harris administration, President Biden signed an executive order on advancing racial equity and support for underserved communities through the federal government, and then actually issued a second executive order 2 years later that focused specifically on establishing equity-focused leadership across the federal government and delivering equitable outcomes in partnership with with underserved communities. These two equity EOs are our tools. It's that top cover, it's that leadership buy-in to say this work is important, you need to do it. The thing and the role of OSTP has been to get the scientific community to understand what that means. Our goods and services of science, innovation, and research, how do we reach and benefit currently underserved communities, and realize that charge of those executive orders. And that work continues. And one of the things I'm most excited about is something coming out of a partnership with the Office of Management and Budget. One of the things they've zeroed in on is we talk a lot about public participation and community engagement. These practices have existed for a really long time. They are not fully implemented, but we know ways that it works, what works, fundamental principles on how to do it well. And this is not just public participation and community engagement in science, but really public participation and community engagement in government. Because when you think about federal science agencies, a lot of that participation is participation in government, not specifically participation in the research enterprise. It's bigger than just participation in a clinical research study. It's serving on a peer review panel. It's providing feedback into a national strategy. So OMB is actually working on a public participation and community engagement federal framework and guidance for all of the federal departments and agencies. And they have an active request for information that closes on May 17th. So if you go to performance.gov/participation, you can actually send in feedback for that. They also have an active prize challenge where the winner receives, I believe, like $150,000 to inform the development of an evaluation toolkit that's compiling metrics and methods for federal agencies to use to evaluate PPC, or public participation and community engagement efforts. So these are some of the things and some of the levers that we're working on, is actually that federal capacity building and connecting the dots between the work of the federal science agencies to the broader efforts to enable public participation and community engagement in government. The last thing I wanted to mention that we're working on from our perspective at OSTP is to find those examples and bright spots throughout the federal agencies where the work is happening, whether or not it's the community-driven research on environmental justice efforts where communities are up front and center in designing the work, whether or not it is the rare disease community really providing that feedback to the FDA on certain issues in order to shape the outcomes of a clinical trial, or efforts like NIH Compass, which I think was mentioned earlier today, where that research is, NIH Compass is a common fund program focused on community-led structural interventions to advance health equity. And they are doing the work. They just published an article in JAMA on their community listening sessions that inform the design and the development of the program. So what we see as part of our role is to take these opportunities where we know the work is happening to uplift and spotlight and figure out how to scale and build that capacity throughout the federal government. And I will leave it at that.
I'll come back to you later for some more depth on some of those public engagement, because it's a very common theme here at the Academy and around the country. But people so often throw their hands up and say, well, we don't know how to measure, we don't know what to do, and there's plenty you could add, I'm sure. Okay, let's turn next to, I know, yes, to Susan Monarez from ARPA-H. Welcome, Susan.
Thank you. And I apologize, I'm not there in person, although you probably are happy that I'm not there in person because I appear to be very infectious with something that I've caught on my West Coast tour this week. So I'm super excited to participate in this conversation, and I truly appreciate all of the remarks of my panelists to date, or so far. So much that is resonating with me and with what we're trying to do here at ARPA-H. So for those of you who aren't familiar with ARPA-H, we're a newly established innovative funding agency in the health ecosystem within the Department of Health and Human Services. And we've only really been up and running for about a year now. And in that year, just to give you an order of magnitude, we've been able to move out about $700 million in funding programs and projects to really drive high risk, high rewards innovation. And again, across the broadest spectrum, how you think about the health ecosystem. We're disease agnostic. We are program manager driven. So our portfolio is a composition of the program managers that we recruit and bring into the organization. And each one of those program managers has identified a very specific problem that they seek to address. Generally, these are long-standing challenges and occasionally emerging challenges, like on the cybersecurity front, that are in need of significant investments to help finally break through some of those challenges and develop tools, capabilities, technologies that will help support improved health outcomes for all Americans. When Victor and I talked about what ARPA-H might be doing in this space, ensuring that science, technology, and innovation is not continuing to exacerbate or to ignore longstanding challenges in health equity, I had so many things that were going through my head because this is such a core part of what ARPA-H does, and it has been a core part of how we were established. So Dr. Wegerson and I, when we first were thinking about, how does this organization need to be new and different, health equity, access, and affordability were core principle. And Dr. Wegerson went so far as to leverage the Heilmeier questions, which, if you've been in the ARPA world, were established in DARPA in the 1960s to really outline and help focus program managers as they were seeking to come join ARPA-H or in their program design. And they're the core questions that one would think to ask, which is, what are you trying to do? How are you doing it? How is what you're doing different than what's already being done in the innovation space? And what are the impacts or outcomes if you are successful? And then some additional questions. What Dr. Wegerson did was add a ninth core question that every single program manager has to answer, both to get in the door in the first place, and then as they're developing their program, and that is, how is what you're doing addressing health equity, access, and affordability? And they're held to a very high standard in account to make sure that they have a very clear definition of how their program is addressing challenges, not just for individuals who have had access to high quality health care throughout their lifespan, but for those who have been historically marginalized or in rural environments or are underserved. How is it that we're addressing those challenges as well? And making sure that it is not just a box that's checked, but it's a quantifiable analysis of those who suffer from any particular affliction or area in the health ecosystem, and how will the product or tools or capabilities that the program manager is developing have a clear, direct impact and improvement on the lives of those who would benefit from them. And when the program managers come on and they're pitching their programs, we actually require them to do a fairly extensive amount of due diligence to ensure that if there is an opportunity to improve the capabilities that they're developing along those lines of equity, access, and affordability, that they do so. And so we have a number of experts that they can rely on internally and externally to really help focus their initiatives. The other thing that we do as we're developing our relationships with our performers is so take one step back. When the program managers are finally approved to be able to launch their programs, incorporated in their program design and in the solicitation are going to be elements that are clearly speaking to these areas of equity, accessibility, and affordability. And the performers are required to propose along those lines as well. And then the evaluation of those proposals, excuse me, is to assess whether or not there is a robustness to the way the performers or the potential performers are proposing. And we've actually had some really great successes in this, both on the program design and also on the execution. I'll just give you two quick highlights. The first, or the two quick examples, but these are representative of many of the activities that we are currently funding. The first is our Paradigm program. So this is a program that was designed by a program manager who works in Philadelphia as an emergency room physician, and excuse me, he has seen how health inequities have, drive the patients that he sees on a daily, weekly, or frequent basis. But he also made some significant observations during COVID about how when you actually can democratize access to the highest quality care, you actually improve the lives and the outcomes for those who, who have historically not had that level of access. And so, he conceptualized a program to take hospital level care and move it out into the rural environment. And we know in rural America, there is an increasing exacerbation of health inequality due to closures of rural health clinics and critical access hospitals, and the sort of systematic distancing between rural health individuals who live in rural America and their ability to access quality health care. And so he has developed this. His program design was really looking at how do you take that hospital level care and you move it into the rural environment in a way that ensures equity, access, and affordability. And the development of his proposal is to develop a mobile health platform that has all of the same level of capability that you would find in a high quality urban environment, and make it available to those in the rural environment. And not only just have the tools and technologies, the widgets on the platform, but making sure that he's democratizing the capability of a provider on the receiving end of this mobile health unit to be able to take care of the patients in front of them, and through a number of different technology enhancements, including ensuring that we have data interoperability and integration, upload and download in real time to allow for continuity of patient care. But also real-time training through AI or augmented reality, AI-enabled or augmented reality, so that you can be a provider in rural West Virginia or in Wyoming and be able to understand everything about what is on that mobile platform as it relates to the patient as it's sitting in front of you, and give that patient the best care possible in the time that you have to see them. That program was launched several months ago, and now we're in the process of selecting the potential performers, and we hope to get the funding out in this fiscal year. Another program which speaks to the breadth with which ARPA-H is seeking to innovate across the health ecosystem is our HEROES program. And that program is saying, can we think about how to improve the health and lives of individuals that have health outcomes that are lower than the national average across several dimensions, including maternal morbidity, mortality, opioid use disorder, cardiovascular disease and stroke, and alcohol-related harms. And not by being prescriptive and saying in community X, Y, or Z, we see that your the population in your area has worse health outcomes than national averages. We respect the people working in those communities that have been seeking to improve their lives and the well-being of their patient populations or their community members for a long time. And what we're trying to say is, you know what's best for your community, but what we want to do is create the financial incentives to allow you, community members, to improve the way that you see and treat those community members or those patients by having a public-private partnership of incentives. So ARPA-H is going to invest in health outcomes, quantifiable health outcomes of improvement a period of time over a period of time. But what we are requiring is that the performers that are to receive ARPA-H fundings get partner funding from private sector. So whether it's private commercial market or philanthropy or others, state funding or local funding, to be able to say that we all agree that we need to invest in improved health outcomes for those populations in those areas that have just been historically underrepresented in the advances of health innovation and clinical care, and allow for the dollars to flow in to improve the way that those communities and those providers and those communities can take care of their patients. That program we also launched just a few months ago, and we're hoping to be able to get our first slate of pilot cities within the next 6 months or so to be able to say, can this type of an incentivized equitable access and improved health equity model work in defined geographic locations across those 4 particular domains, and if so, how do we scale that, and if not, how can we think about this differently? So those, again, just 2 representative examples of specific programs that we're investing in to demonstrate that it's not just rhetoric when we start to talk about ARPA-H and ensuring that we have equity, affordability, and access, but it's translating into our programs and how we think about the patients and the populations and the providers and even the payers that form the sort of the constellation of influences on ultimately improving the health outcomes. So I'll stop there, but happy to.
Yeah, it's a very impressive launch, and I'm sure we'll be interested to hear the assessments of these experiments and different social experiments. There's a lot at stake to try to show that these actually make a difference. And of course, it takes time. Will there be an interim assessment in like 2 years, or will this go for 3 to 5 years until you have any feedback on how well these objectives were met?
Yeah, so I'll start with the HEROES program. Our intention is to evaluate it on a over 6 month basis so that we can see what's working and what's not working, and our goal is to be fully transparent. We already have, if you go to our website, you can actually look at our data models so that you can go to any jurisdiction, you can create your own catchment area to see where you live and work. What are the current health outcomes across those 4 dimensions, and we want to be very transparent as we're seeing progress or we're not seeing progress. We will make that information available.
Okay. Well, of course, DARPA is famous for intervening on early impressions. I take that's part of the DNA of the ARPA-H as well. Okay. Thank you so much. Let me come back to Erica and ask, what are the metrics that you're applying? I mean, it was impressive what's been done with executive orders and with OMB directives. What's the plan for evaluating the implementation and the feedback and lessons learned from those initiatives?
So I would defer mostly to my colleagues at the Office of Management and Budget, who have been running most of the process related to the equity EOs, but what they've done to coordinate progress and to get agencies to commit to progress on equity is there was a whole phase in the beginning where they had agencies do an equity assessment within the first 6 months or a year, and we're incredibly rigorous in terms of what they were asking and the structure of those equity assessments from each of the main federal agencies, and then come up with an equity action plan that addressed the issues surfaced in those assessments. So the way OMB has really been pushing this forward is by just having a standardized approach to what it looks for from agencies, and then what it asks for them in return, and then they post those equity action plans publicly. I think it's on equity.gov. So using that as a way of having accountability publicly, but I think this is still early on
stage,
in order to know the full impact of them.
And Holly, in your research known to you about IRB performance and investigator compliance, what kinds of studies actually have been carried out, And what are the findings, good and bad, that you can share with us as a sort of sample?
Yeah, well, so I'll put to the side kind of what we know about IRB quality, which is not very much. I mean, I said I'll put to the side, but I have to comment a little bit on it, which is to say, IRBs have been around for several decades, right? They were, as Dr. Nelson said earlier today in response to your question, actually, right? IRBs are not perfect, I think she said, but they're better than not having them, which I agree with. But we have challenges in evaluating the IRB system, which is an area of my work. But I'll focus on this topic of IRBs and equity. And there's a lively conversation happening right now in the IRB community about whether this is their ball of wax or not, right? Whether this is something that's reasonable for IRBs to kind of push back on investigators to say, wait a minute, right? How are you going to address equity in this protocol? What are your recruitment and retention plans? And the reason that there's some, in my view, it's very obviously within the IRB's domain, right? It has to do with the risks and benefits of research, making sure that the benefits and burdens of research are appropriately distributed, right? The ability to promote social value of the research that's done. All of these things, I think, are clearly within the IRB's jurisdiction. But what's happened over time, as investigators have been more and more annoyed by IRBs, is that we have pushed back on them. And we've said, show me in the regulations where it says that you can ask me that question. Right? And so what the result has been is IRBs have been told by their institutions, hurry up, right? What's your turnaround time? How efficient are you? Show me in the regulations where you can ask these questions. And they are no longer, in my view, really accomplishing their goal of ensuring that the research that we do is the highest ethical quality. Their job has become regulatory compliance. Right, and the function then turns into this audit culture, box checking, and we need to, as researchers, say, wait, it's okay for you to ask us about this. You should be asking us about this. You should be holding, me and my colleagues' feet to the fire to make sure that we're doing high quality research, which includes equitable inclusion.
Well, of course, there is a problem in most institutions in getting enough faculty to be willing to participate on IRBs. Isn't that true?
It is true, and interestingly, there was a report that came out about a year ago that indicated during COVID, the for-profit IRB sector overtook the academic IRBs in terms of who's responsible for overseeing FDA-regulated drug research. And I could talk all day about this, I will spare you from that, but one interesting thing about that is there's pros and cons, both of the for-profit IRB model and the academic IRB model. A pro of these commercial IRBs is that it's people's day job. That's what they do all day, is review protocols, right?
And not as resentful.
They're not doing it, as their kind of side job, their faculty service role, and so you get their full attention. The downside is that they're a business, right? And who's the customer of those businesses? The sponsors, right? The investigators, not the research participants. They don't get a say in who's reviewing that research. And so the business model, I think, can very easily fall into this model of turnaround time.
Huge conflict of interest. And let's go. On the NIH, you said that your institute has about 15% of the disparities research of the NIH as a whole. How can you characterize the rest? Is there any process of looking together with your fellow institute directors or their designees at the disparities research across the whole of the NIH?
Yes. As director of NIMHD, part of my job is to develop a NIH-wide strategic plan on minority health and health disparities. And we did accomplish that for the first time. It's 2020, 2025. Prior to that, there was a plan, but it wasn't really a coordinated effort. And so we wanted to create a strategic plan that was readable. Someone might actually read the whole thing, and have commitment or participation of staff from across all the institutes. Before and it went through a lot of clearance. So, and it has to go to, I guess, sent to Congress. It doesn't have to be approved by Congress. Our institute has a lot of political ties that is part of the Affordable Care Act. So that's really, you may be familiar with that. But in that process, I asked each of my peers to say, okay, let's create aspirational goals. And here are some examples of what we could do in your institute. And some of the directors said, yeah, that sounds good, let's do that. And others said, no, we don't do that. We define mechanisms, we do research, but we can't expect to change outcomes in the population. So I think it was about 50-50. I got mixed on that. And so I think that's a process that was satisfactory. We're now in the process of evaluating what has been done so far. We're about a little past midpoint. So, and we usually measure it by the dollars that have been invested. That's the first metric. And the second and more important one is, what have we done and what has changed? What have we made a difference in? So I do think that it's going to be an important continuing effort. I do want to make a comment, if I can, is that we talk about equity, and everybody says we should promote equity, and IRB should promote it, the business should promote it, but does anyone know what we mean by that?
What's the measure?
Because it just sounds good. It's like saying I'm for this, and it sounds good. And Susan was saying about communities that are below the average. At least it's a start to say, okay, we look at the mean for the country, and so we're going to look at communities that are in the bottom 50% or bottom 20%. Frequently in my field, everyone was saying comparing to whites and generating models with relative risk or odds ratios. And I think we have to stop doing that, and we have to sort of think about where should we be, and perhaps different populations might not ever get there, but we should try to say, we should set these aspirational goals and say, where should we be? And then figure out how to get there and compare by the measures that I mentioned earlier. So.
Please.
Yeah, I just wanted to respond to that. I agree. It was something I was thinking about as well, which is, equity isn't just like a modern word for equality. It's an opinion. It's an opinion about what equality is, and it's an opinion about what the morally allowable causes of inequality are. So, to as best as I can understand it from the many conversations that we're in as well, and the work that we do that really is more than nominally oriented toward equity, equity is an egalitarian doctrine that says individuals or units of individuals can compete for advantage, but background conditions really matter in that competition. And two, there are very specific socially significant categories that are durably responsible for background conditions that consistently advantage certain populations and disadvantage other populations. So I think to your point, Eliseo, I think that means at least a couple really complicated things for biomedicine. The first is we do actually have to say what we think reasonable goals are. And those goals have to be specific enough that you can manage to them, but capacious and flexible enough that as your understanding of the role of background conditions and your understanding of what it really takes to thrive evolves, you can begin to evolve those goals as well, as opposed to continuing to freeze a suboptimal understanding of what a just society is. But I think the second and more complicated thing that it means for biomedicine is that the institutions that are responsible for determining what constitutes authoritative knowledge have to have an opinion about what background conditions matter and how, right? So, a good example of this is that in the area that I referenced that Doris Duke is working in earlier around the use of race in clinical equations. One of the really interesting emerging arguments is it's the equity-oriented version of the argument. We won't want to just take race out because we know that that can lead to harm. We don't want to just leave race in lazily because we know that that is leading to harm. So what we want to do is be race conscious. Well, what that means is to be conscious, to be aware of how background conditions are actually shaped and the way in which those background conditions around race as a socially significant axis of organization in the society are affecting this particular domain of medicine and of medical practice. And if you agree with that, then that has some implications that I think will be challenging for some people in this room. It means that journals, for example, probably need to do more than just say, explain how you're accounting for race or collecting racial data. It probably has to have an opinion about what the right way to operationalize race as a variable is for research to be considered authoritative. That will be a political and moral opinion. Inevitably. It is inevitably a political and moral thing to do, to say that. Similarly, I think that we'll have to start saying what race-conscious research design looks like in setting up funding. And we'll have to do the difficult work of, again, saying something specific enough that it actually changes what research is in and what research is out, but not so specific and overdetermined that we don't end up either kind of freezing our contemporary understanding or making the problem worse than it already is. There is one thing though that I think we do know is not a panacea, but is a shortcut to accelerating a lot of this. And I won't spend a lot of time saying it. We have seen in institutions that representational diversity makes a huge difference in this. So it's like, that's the quote unquote easy way to get going on this really quickly. If we build better, more effective, faster representational diversity in these authoritative institutions, you will just see in the normal workings of these institutions the incorporation of what I'm sort of articulating as a race-conscious perspective. But we know that, we say it a lot. Obviously, the hard part is doing the work of making that, or the seemingly hard part is doing the work of making that happen. So I'll stop there.
Okay, so we in our preliminary discussion had some ideas around this topic of governance of emerging technologies, innovation. And I suppose before addressing the questions whether there are changes needed in governance to address developing or worsening inequities, we need to first agree what kind of governance exists other than budgetary review on grants already awarded. What kind of governance do you feel that your funded investigators and institutions expect and respond to, and so forth? We'll hold you for last since you just spoke. Let's start at the other. Maybe we should start with you, Elisco, because you are an agency that actually makes the grants.
Well, you mentioned governance. Once an R1 is funded, the investigators pretty much do what they want, as long as they report every year. It's a fairly open, license to do science. And my friends in basic science say that often the investigators have already done the work of the grant that just got funded, and they use the money to develop new ideas. That doesn't happen in the funds and the grants that we fund. We don't, we do have a small business allocation, so I think that they are charged with, evaluating and testing a technology in that regard. So that's closest that it comes for regulation. But I don't think that we have a specific sort of governance. There are other mechanisms that allow more back and forth, such as how ARPA-H operates, this other transfer authority, and we have created just as an example, a community engagement alliance that's done through NHLBI, the Heart, Lung, and Blood Institute, and NIMHD, where we're funding 22 teams to create an infrastructure for community engagement. So academic community partnerships. It started with COVID, and now we're pivoting to chronic conditions. And because it is other transfer, that you can set, what are you doing in the next 3 months? Have you achieved your goals? If not, let's negotiate, renegotiate, and so forth. So it is closer to that. But to my knowledge, I don't know. Devices are approved by the FDA without any clinical trial data, right? So it's just basis of
There's extensive,
safety,
no, they have a lot of review of
Safety.
devices. Safety, of course.
but not efficacy, or not better than we already have.
Is that right? Doesn't sound right.
So,
Victor?
It depends on categories of review by FDA. Some are clearly efficacy and safety dependent. Some of the low technology is really a matter of safety.
Okay, thank you. Want to comment?
I think the idea of governance came up earlier, and it becomes tricky when you talk about a specific technology. And we were just having one of the side conversations I was just having was focusing on a specific technology feels like the wrong way versus a full sector of governance. So like, I think by the time we're talking about an individual technology, it's already the cat's out of the bag. And then what Dr. Nelson was bringing up in terms of then there's kind of the capitalist system regulation of a topic. What I wanted to bring into the conversation in terms of the tools and structures that we already have, and thinking about ways that, and these are not answers and these are not like formal policy, but there are things that are built into current grant funding mechanisms that are where researchers are supposed to consider things like the implications of the technology. I am thinking about, like, NSF has had broader impacts for like over a decade now. The evaluation and the post-reporting of a grant, you don't have to talk about your broader impacts. You know, we haven't fully realized or revisited since we've added responsible conduct of research training into NIH, what that actually means for how a person operationalized it. So I think the issue that I'm raising is in the ways that we already have our touch points with researchers, like RCR training, asking for broader impacts, if you have any built in for equity considerations, how do we think about new opportunities for follow through and reinforcement of those principles and making them meaningful in the assessment of how we talk about science and technology? So this is not an answer, but just pushing us to think towards building off of the mechanisms that already exist so that we're not adding new burdens and new considerations in, because I think there are some structures there that we could potentially play with down the line.
Okay. Melissa, what's our timeline for going to the audience?
I think we can move to the audience maybe in the next few minutes, and we can go a few minutes late. I know we started about 15 minutes late,
right.
So maybe we can wrap up around 3:35, 3:40.
Okay, good. Please.
One of the things that I find interesting as kind of an observer of this ecosystem is that it's all about science and evidence-based practice and learning and innovating and iterating. But it's important to apply those same principles to the governance that we try, right? And making sure that we have evidence-based policy making. And so just to take the example about the diversity action plans at FDA, right? So FDA said, all right, we'll do this as guidance. Then Congress says, no, we're going to require it. And then what will happen, right? Are we sure it's going to achieve the right goals? What kind of checkpoints are we going to have? What are the right goals? And actually there could be, I think, some pretty substantial unintended consequences of saying, okay, now we're going to make sure that we are focused on race and ethnicity in our clinical trial recruitment. Right? Well, what's your hypothesis that your populations are going to differ in their outcomes by race and ethnicity, right? In many cases, your hypothesis would be the opposite, right? That scientifically they wouldn't differ on those domains, right? They might differ, in response to socioeconomic status, neighborhood, environment, other things like that. And so we could end up entrenching things that suggest there are biological differences when there are not. And so I'm just using that as an example to suggest that when we should experiment and try new things in governance, but we should make sure that we then pause periodically to say, what was the goal this was intended to achieve? Is it doing it? And what adjustments do we need to make?
All right. So one of the elements of governance should be public engagement. And we've talked a lot about the importance of public engagement. We have a lot of variety of experiences. I remember years ago when I chaired the Presidential Congressional Commission on Environmental Risk Assessment I mentioned this morning, we had terrific public inputs on pathways of exposures and on practical ways of reducing exposure that were not so expensive as what was thought to be required. What's the experience here from public engagement around governance on these topics? Has it even come up?
I'm assuming that question was for
That's
me. I
yours.
just, so not the governance of these topics in particular, like in the context of my work. I am more broadly familiar with, having spent a lot of time on public participation and engagement prior to my time at OSTP. It does exist. Like in the UK, there are citizen juries that talk about the implications of certain AI applications. There are participatory technology assessments that are done via the folks at Arizona State University. You know, the work is happening, but it is not kind of centralized and systematically deployed against certain biomedical innovation. So I think there's a lot of room for that capacity building. There is one thing I just wanted to bring up while we're talking about public engagement and to getting some of the, like, we have to be real, like, to the point that equity, people don't often specify what they mean by equity. We often don't specify what we mean by the public. And that is to our detriment, because it, you know, that idea of the monolith, like, we have to be very specific about who and why and when. And I think the biggest lesson learned I've had in this space is I start every conversation, well, who are you trying to talk to? Why? Like, what's the purpose? Like, you can't just go in to talk to them when you want to extract information from them. Like, I think the biggest challenge we have is actually getting people to think about public engagement away from the one-off and into something that is developing an ongoing relationship, and not coming with a preset notion of what you're going to do in mind, because for it truly to be engagement, you actually have to be responsive and not be using it to confirm your, you know, what you're intending to get out of the engagement. So what we don't have is a lot of systems and structures that have that flexibility in terms of time and capacity, and seriously the expertise that can, like, that you need in order to do inclusive, accessible public engagement, which is often undervalued, that it is an expertise and not every scientist can do it. You know, you need to bring in people who know how to do it.
Of course, a lot of the relevant information is in websites these days, and yet we face a digital divide. Hasn't really decreased, I'll bet. What is your thinking on that subject? Why don't you take that?
Say more about.
You know, if we're asking people, if we're telling people we're eager to have their opinions and hear their questions, other than the formal rulemaking processes, which are very well specified, on these topics about equity in clinical research, let's say.
Yeah.
How do we explain our questions of the public in order to stimulate useful responses?
Well, I mean, I think maybe building on Erica, I think some of what I think I hear you say, or some of what you say, it would inspire me to think. What is the right kind of public engagement, right? So one of the areas. So let's use a really concrete example. Again, I'm just sort of thinking about the area that we're working on that I've already mentioned today of race and clinical equations. You know, one of the things that we probably need to see in research on building a diagnostic algorithm is the inclusion of sociologists who are working in and around medical settings in which patients of different races, which we know to be a socially significant variable, are getting treated, to sort of understand their experience of these different diseases and these conditions, whether that experience is sort of racialized or not. That's an academic and intellectual technology that we have that may or may not be mediated by digital means. You just need to include sociologists on your research teams who have authoritative methods for gaining this kind of insight from populations. So that's something that you can do that's not sort of broad public engagement. A similar, one is, think all the way downstream. The most important setting in which you may need to get information about the role that race plays as a variable or not in a clinical equation isn't at home, it's in the doctor's office. And so making sure actually that sort of doctors as an elite public are first engaged about this and understand how these equations are formed, the role that race plays in them or not, and then how to be trained in how to talk about it. And maybe not just doctors, but others in clinical settings, trained in how to talk about this, and providing patients with information that they can actually use and respond to. So I think there's no question that digital tools are potentially incredibly powerful amplifiers for our ability to communicate and engage the public. What we shouldn't do, though, is sort of use them to distract us from the first order task, which is what, to your point, Erica, who do we want to engage? Why do we want to engage them? How is that going to affect what we think, to your point, in terms of goals, the ultimate outcome is going to be for our population? And then let's figure out how to use the technologies, whether they're kind of legacy or emergent, in order to engage those publics.
Very good. Okay, it's time to turn to the audience. Who would like, a few hands are up immediately. Good. Please, Picori.
Hi, this is Tracy Wong from Picori again, and I really enjoyed this session. I just wanted to share a few perspectives from Picori because I think there are some differences in how we think about funding and oversight. One is that sort of engagement piece is there from the beginning. So an investigator can't get their foot in the door with a funded application until they've actually proven that they've engaged with a community stakeholder, particularly on the health equity issues. So the question is co-designed with that equity problem front and center. They also have to demonstrate, and this is a foundational expectation for us, they have to demonstrate early as well as continuous engagement throughout the research process. So these partners are very much part of how the study is not just designed, but conducted, and then the results are disseminated. When the results are done, there is an expectation to return the data to the participant. That is an expectation, and more than 85% of our projects have done that. But the results are also peer-reviewed, and we have a slightly different definition of peer review in that, you know, you've got the journal peer review sort of definition. We have a peer review definition that's slightly more broader in that it's peer review from scientific peers, but peer review from the community that stands to benefit from that. This is part of the reason why people love Picori, but also hate Picori, because we have these requirements, these needs here. And the other thing is we don't issue grants, we issue contracts. So we build them into our milestones. You can't invoice unless you achieve a milestone. And so that makes it a requirement, and that's part of our teeth in being able to sort of provide that kind of funding oversight and requirement for this. So I just kind of wanted to share some of those insights because I do think there are examples of ways where funders can be more demanding in terms of making health equity a priority.
Absolutely. Keith?
Right. I just wanted to echo what was just said and to highlight that, you know, on the one hand, one could say, what is equity? But when you have an answer like the one we just heard, it's clear that there are people whose model is not only centers these issues of engagement and equity, but part of the argument is that this model should actually be far more integrated elsewhere in the innovation life course, whatever you want to call it, model. The other is, I just want to echo what Holly said about that embedding equity also involves, and this is a conclusion of the report, embedding ethicists. But also expanding to other scholars who are in the health humanities and social sciences to help inform and develop this approach. And then finally, you know, on the question of what is equity, you know, one of the goals, one of the recommendations is to make that a scientifically answerable question. That is to say, a commitment to building the field of equity metrics, equity benchmarks, so that it isn't just a kind of like a, you know, gesture that is appealing, but it comes with benchmarks and metrics. And I think, you know, I applaud Sam Gill and Doris Duke because you've been developing that, as many others. So just a number of comments about why I think, you know, what we are in a position to do is to actually learn from those who have been doing this and spread that perspective elsewhere.
Right. So let me just say that both the NAM staff and the OECD, Dr. Winokur, to stress that there were metrics and milestones, but we haven't heard much about their actually being applied yet. And I think this point deserves major emphasis.
This has been such a rich discussion. Is what I hoped we accomplish, and certainly we have. But it also opens up a lot of steps going forward, right? So in terms of hearing from Priscilla about the grant funding, the contract management, ARPA-H, and all the other stuff, I think this is in fact what I hope that, but we call this funding and oversight mechanism to enable us to go forward. I think what's really important is what Keith and many of you said. You have to define what you want to measure, and that's not so easy. So my question has to do with Holly, spot on about tech transfer. Spot on. Now you tell the tech transfer officer, what do you need to evaluate to be sure that in fact it goes along with our value of the university, organization, and how do you measure going forward, right? That's really difficult. And same for Susan. When you're project managers who are really managing projects, but you can say we have a 10-year agreement with you that you need to meet these opportunities. What are they? And can you enforce it? That's the question. So for both of you.
Good. Do you want to go first?
I think she thought you wanted to go first.
Oh, I was asking if you wanted to go first.
I'll jump after you.
Okay. Yeah. So I'm drawing on a project that some folks in my department and I worked on a couple of years ago now, although the paper was just published recently, where we looked at university roles in drug pricing. And one of the things that we centered on was how are the tech transfer offices being evaluated? And they're being evaluated in a very clear way, revenue. Right, and the individual tech transfer officers, right, get bonuses based on revenue, right, and so of course, right, you follow those incentives, and so it's the types of things that we were thinking about in terms of benchmarks and metrics are affordability and access of the products that are developed through universities. Now then you have to figure out what counts as affordability and who has to have access. We do have models of this in terms of low and middle income countries, right? There are licensing templates and things like that, but there has been way less attention on the domestic side, where we've already heard today, right, these same kind of access and affordability challenges come up. So we haven't nail down what the benchmarks ought to be, but I agree with you, and this links to Keith's point. You have to bake it in from the beginning. You have to have evidence-based approaches, right? And you have to know what you want to achieve on the back end. And so we have, we have this kind of approach to implementation science now. And so I liked what you were saying before. Now maybe we have equity science, right? And it's going to be, we go back and evaluate against these measures whether we've achieved the goals. But I think it all does come down to affordability and access globally and domestically.
Susan?
Yeah, so I'll just jump in here really quickly. Victor, great question. Just going back to what Alicia was talking about, ARPA-H has the OT authority to be able to be very prescriptive in our contractual relationships with our performers. And one of the things that we do with our program managers, even before they launch a program, is we make them do an evaluation of what are the potential costs associated with their tool or technology. Now, much of this is going to be completely innovative, and so we do the best benchmarking we can, but we know that we can't fund the next product that's going to be cost prohibitive and be $1 million or $10 million per treatment course. We want to make sure that we are very cost conscious, realistic, so that if we're creating something new, it's at or below the current price point of anything that is in that space, whether it's a sort of a product that is sort of in imagine neurodegeneration, something in that space. We know that we have to be below that cost to make it, and sometimes significantly. And so we design that into what we're asking performers to propose to. once we actually, so we know that we're driving towards cost-effective tools, technologies, and products, because that is a requirement of our program managers during their concept design. When we actually have the ability to put in place the statement of work, the performance work statement, we're signing on the dotted line with our performers, we will be very prescriptive, or as prescriptive as we can with that performer, that if they are successful and they receive our funding over the course of 3 to 5 to 7 years, and they produce the thing that we had sought based on that particular relationship, that contract, and that in alignment with that program, we don't know, Victor, your question is, can we hold them accountable after we are no longer in a contractual relationship and they've spun out a commercial product and whatnot? Obviously, we hope they will be, but we're actually testing that. We're testing more than hope in one of our first programs. It's our Nitro program, where we are seeking to have an innovative solution to osteoarthritis through a very, very different technological solution. The performers, when they signed up to receive our funding to produce this, single shot and restoration of bone and cartilage in a for knee, hip joint replacement, that they would, if the technology comes to fruition and they're able to move it out in the commercial sector, they would keep it at or below a significant amount, significantly below the prevailing market costs for a traditionally funded knee or joint replacement, an artificial knee or joint replacement.
Yeah, it might help to inform them that you will keep monitoring the situation, because there are likely to be reapplicants someday.
That's great. And
Let me go on. Next, yours.
Okay, thank you. I was pushing the wrong button. Holly, your first set of comments made me really think about...
Introduce yourself.
Your first set of comments really... Oh, I'm Preeti Sivasanka. I'm at Purdue University. And Holly, your first set of comments really made me think about institutional culture, right? So we've touched upon the role of universities. And of course, when we think about the innovation pipeline, thinking a little bit about what universities prioritize when we're thinking of promotion and tenure, right? So many of us are affiliated with R1 universities, the rest of us trained with them. And I think this begins with the university recognizing that equitable innovation is critical, right? And is a path to promotion and tenure. So I think it really begins with rethinking what our institutions prioritize when we think about scholarship and promotion.
I just wanted to add one other point to that, which thank you for raising it. But equity sometimes takes longer, right? And it's okay that it takes longer, right? This community engagement process can slow things down. I mean, again, to bring it back to the IRB space, that was intended to slow researchers down for a minute and say, wait, think before you do this. Is this an acceptable, thing to do with research participants? You can do efficient community engagement, but it's going to take longer than not doing it, right? And so it's a tension, I think, in the innovation space to do genuine community engagement. Because what if the community says, we hate that idea, or do it this way, or you haven't thought about this, go back to the drawing board. You can't just ignore it, right? Or why are you doing the community engagement? And so that, it's relevant across the board, but in the context of universities in particular, if you have people who are really doing community engaged research, they're not pumping out papers at the same rate as their colleagues, right? And it is a challenge, right? We're all motivated by incentives, and I think our incentives are often misaligned in the academic space.
Just to build on that for a second, too, I think in addition to the timelines being misaligned, I think our systems for promotion, tenure, advancement, all those things also don't value qualitative impact metrics and high numbers in terms of publications, like amount of money brought in, like those are easier to quantify. And the qualitative impact of the work is also, we're going to need to build a system that can bake that in and be comfortable finding value from qualitative metrics in addition to quantitative metrics, because you can't really assess equity through a single number. You can't assess effective community engagement through, like you can reach 10,000 people with a YouTube video, but are you changing behavior? Like we've had these conversations before. You actually have to have a nuanced perspective and define what you want to get out of it. And our systems for assessing impact don't really account for that. And that's going to continue to be a struggle until we have a concerted effort to start to really embed these alternative metrics into our work. And that's where I think we can actually learn from people abroad. I think Europe and the UK are doing a lot of this work in different ways, and having worked with them in the context of OSCP, like there's a lot we can start to learn from other countries as well.
Sam?
Yeah, I mean, my sense is that sort of most of this is a broad generalization, but sort of most of the incentives around scholarly and academic production, of which tenure and promotion is one structure, but they all, it works together with journals and sort of other elements, is that it's testing for three things. The first is the knowledge that you're producing authoritative? That's largely what peer review is for. The second is, are you efficient at producing knowledge? And that's why there's an incentivization for not just quality, but quantity of publication. And the third is, are you an effective member of a knowledge-producing community? And that's some of the service requirements and things like that. It seems to me you've got sort of two related design challenges that you want to solve. One is, if you make things that we think are required for equitable research design and practice, like community engagement participation, something else that counts, as opposed to counting in place of the things that count today, then you're not really going to get a great result, because sort of the nature of a systemic problem is that it's really inconvenient to do things to challenge that system. So you're going to have people who, to your point, are going to have they're going to have a lot less publications because they're doing a lot more community engagement. They'll ultimately be disadvantaged in that system. If you make it required, though, if you actually sort of substitute out things that you think are distracting from or detracting from practices that you think are conducive to equity, then you get an endogeneity effect. Then the researchers who are going to move on are going to be the ones who are incorporating those things, and the researchers who publish lots of papers and don't engage community won't get promotion. They won't get tenure, and it will be a lot less prestigious to just be really efficient at doing that kind of research. So I don't mean to minimize these design challenges. I think they're incredibly complicated to work through, but they are tractable. We're getting the result that our academic system is intended to produce. The problem is we think it's no longer conducive to the full set of social values that we want systems of knowledge to promote.
I don't totally agree with that, which is all of the opportunities that we have to impose metrics have the opportunity to be gamed, right? And we see that in the IRB space, right? You end up with these audit cultures, this box checking exercise. And I'm sure all of us could think about our colleagues who are so great at community engagement, and our colleagues who claim to do community engagement and talk to the same patient advocate every single time, right? And so it's not full disagreement. It's that we have to make our metrics less gameable if that's going to work.
And we have to actively audit these systems. I mean, I agree. This is sort of why innovation and efficiency trade off. Like, mostly a large-scale system it works because people just manage to a proxy. They don't often manage to a proxy with total fidelity for whatever the social goal is that proxy is meant to serve. They manage that proxy because for self-interested reasons. I want to move up and be rewarded. So I think we're actually in agreement, right? Which is you don't figure it out one time. You try to continually improve the proxies, and then you audit rigorously, aggressively, and in an open-minded kind of way. Is that more of a synthesis? Yeah.
Okay. Well, let me thank our panel on behalf of the audience. And we also thank those of you who got to ask questions. It was a good, lively session. Thank you very much. Do you have any break, or are we going straight?
We'll take about 2 minutes to transition panelists, and then
Okay,
roll
we're ready
right
for the
into
new
it.
panel.